This is Chapter 6, Childhood Communicable and Infectious Diseases. So let's first talk about infection control. Hand hygiene is our most important way of preventing the spread of infection. With everyone, we're going to follow standard precautions and then know the difference between some of the other precautions. Airborne is for things that are such small particles they can float in the air for a long time. This is TB. With kids, it's chickenpox and measles. If you remember the big measles outbreak in Disneyland, the problem with these is you just walk by somebody and you can catch them from the air. That's not true of TB, but we still use this airborne precaution in TB. TB is not as easy to catch, but measles is very easy. Droplet. This is also things that come out as you breathe, cough, sneeze, talk, but the droplets are a little bigger, so they go a few feet and then fall. So they're not going to float in the air as far. But if you're caring for a child with, who's coughing and your face is close, within a few feet, you're going to catch it. Contact is for any sort of secretions that are infectious. So you'll see at children's we often have contact and droplet because the kids sneeze up their airborne or their respiratory germs. They land on all the surfaces around them, and then people touch those surfaces and touch other surfaces and move them all around. So you should consider every surface infectious when you have contact isolation. I just added this slide in. If you're not familiar with those terms in box 6.2, you should be, because on the exam I'm not going to explain those terms. They'll just be used and I'm going to expect that you know them. So immunizations. Immunizations are probably the biggest improvement we've had in childhood health. We do have a lot of people questioning them now, but if you talk to anybody from your grandparents, great-grandparents, everybody lost children to common illnesses. So they've made a huge difference. How do we know what to give? It's based on these advisory committees. And there is the CDC and the American Academy of Pediatrics makes and then periodically revises the recommendations for the schedule of immunizations. And these are the ones we routinely do. Hep B, Hep A, you're used to either DTaP or Tdap, which is diphtheria, tetanus, and pertussis. Polio, which used to be oral drops, it's now all injectable. Measles, mumps, rubella is the MMR. Hib, which is Haemophilus influenza, that's in italics because that's its scientific name, because it's a bacteria. So when you use that scientific name, bacteria are always italicized. Varicella, which is chickenpox. Pneumococcal influenza being the flu shot, and meningococcal, although meningococcal is really kind of high-risk groups right now. It's not necessarily everyone. And here are the recommendations. I just pulled this off of line from, I don't know if it was the CDC or California, but recommending the schedule for your shots. You need to memorize this. There will be a question or two on the exam asking you what shots to give at what age. So our biggest shots are 2, 4, and 6 months. We should have had a hepatitis B either at birth or within a few days after. A lot of our pediatricians here like to have the child come back in a couple of days after discharge to be able to see them, weigh them, look for jaundice, that sort of stuff, and give that shot then. Other places do it before the child leaves the hospital, but they get their first hepatitis B at birth. Then at 2 months, that DTaP, Hib, that's the Haemophilus influenza, remember, pneumococcal, polio, rotavirus, and Hep B. rotavirus, there's 2 different brands. One you give it at 2 and 4 months. The other you give it 2, 4, and 6 months. Just depends on which immunization brand is being used. This is time sensitive. If it's not completed, it's not given. The others, if somebody gets behind, we go ahead and catch them up. But this one, if you haven't finished it on time, you don't get it. At 4 months, very similar to 2 months. 2, 4, and 6 are pretty much the same. Then at 12 months, you come back in, and this is where you start Hep A. You get the last of the Hibs, pneumococcal. You start the MMR and the Varicella, and there's some combinations they have now of those. At the recommendation is at 15 months, the last DTaP. At 18 months, the Hep A, and then before school you get a booster of just about everything. And then before 7th grade, we're now starting boosters of, or we've been doing that for a few years now, having boosters. So contraindications and precautions. There is nothing that we do that's not without some risks. The risk of not being vaccinated is considerably higher than the risk of vaccines, but nothing is without risks. So, those people who are against immunizing their children, that's what they focus on, the risks of the vaccine. But we're not going to give a vaccine if a child is very ill. Now, if they just have a runny nose and they're whiny, they'll still give it. They have to look acutely ill. A child who's immunocompromised, we will not give a live vaccine. In the DTaP and the MMR, we have live vaccines. Actually, the DTaP, that's not exactly a live vaccine, but the MMR is and the Varicella is. So if they're immunocompromised, or if they have a family member who's getting chemotherapy, something like that, we'll hold off on those live virus vaccines. If they have, anything that makes them immunocompromised, if they have a known allergic response to a vaccine. Now, this doesn't mean they run a fever afterwards and they're really fussy for a couple days. That's an expected reaction. When we talk about allergic response, we're talking about a severe allergic response. They had seizures or something like that. We do want to deal with parental fears because there's a lot of misinformation out there. And most states allow for not giving them for religious beliefs. Every time we give a shot, we give this vaccine adverse event reporting or vaccine information statement, which includes the VIRs. So anytime there is an adverse reaction, it gets reported to the health department, and those are tracked. So, which is why I can say we know, we have statistics that show not being vaccinated is more risky, considerably more risky than vaccinating. But occasionally there is somebody who has an anaphylactic reaction or develops seizures or something like that. So we do give that information to every parent before every set of immunizations. So let's move on to communicable diseases. We have seen a huge decline because of the widespread use of immunizations. If you go to third world or even some developing countries, you're going to see all of these diseases that are very rare anymore in the U.S. But we also have antitoxins and antibiotics and ways to treat these diseases if they do happen. So we have a lot less problems than we did in the past. So if you have a child, you want to ask if they've been exposed to an infectious agent. And this is not in the last few days, like for a cold. Most of these things have a long incubation period. Chickenpox is up to 3 weeks. So we really need to ask, have you been exposed in the last month? Not, people are going to assume we mean the last few days. And then we're going to ask about those prodromal syndrome symptoms, those things you start feeling first, because some of them are very characteristic, especially certain rashes, will lead us into being able to identify what they have. Immunization history. If they've been immunized, it's not this, so it must be something else. And most of the childhood diseases are things you get once and then you have lifelong immunity. That's not true of all of them, pertussis being an exception. But most of them, if they've had the disease, we can rule it out. That's not what they have this time. So how do we prevent the spread of these diseases? Well, immunize is the most important, and then follow our infection control protocols, such as hand washing. At children's, we gel in, gel out, every patient, every room. Teaching kids sneeze and cough etiquette. So cover your cough. We do want kids coughing. We don't want mucus sitting in their lungs. We want them to bring it up, but cover your cough. Use a tissue. Don't cough towards people, cough away. Wash your hands. Throw away the tissue and wash your hands. And then our goal is to prevent complications. So if we have a child who comes in with a communicable disease, we need to make sure we implement isolation precautions. We do not have to wait for a physician to order it. We can put up isolation. That is nursing prerogative, at least at Valley Children's. It takes a physician's order to take it down, however. So if we put it up and find out it's not what we thought it might be, we need the physician to DC the precautions. With these kids, a lot of times they're going to have some discomfort, ear, nose, throat pain, the itching, fever, pain, irritability. So some Tylenol for those things, and then supporting the family. Families are very frightened when their child has to be hospitalized. And now we're going to move into the diseases, so I think I will stop here.